Today's topic is called Sick Around the World. I don't know whether any one of you wonders why we named the class Sick Around the World instead of Health Around the World. I don't know, but maybe we will find out. So before the class starts, as usual, we want to know your opinions and values and ideas about some of the issues that are related to this class. So I will have Professor Chen ask you some of the questions. And then for those who are using this for the first time, this is called IRS. It is basically like a remote control, okay? And you will just press the numbers according to the answer, the option that you want to do. So you can press number 1. For example, right now on the screen we have 5 options. So if you want to choose 1, you just press 1. And remember to point your remote against this receiver, okay? So we can do the statistics later. And if you want to change your mind, you just press another number. So just 1 press, your answer will show, okay? So let's just try with the first question.
Okay, the first question is the standard question we ask to a sample of about 3,000 citizens in Taiwan. So I'm posting this question to all of you, all right? The question is about the National Health Insurance Program. So we are saying that, are you satisfied with the current National Health Insurance system? The Bureau of National Health Insurance or 中央健保局, they have been doing this on a quarterly basis for more than 15 years. And every time they sample about the so-called representative sample of the country, about 3,000 people. So I'm doing this assuming that you are representing Taida. So how do I get to read the result?
So the students, after you read the question, please choose the result. I mean, choose your answers.
So there is a... Okay. Okay. Next question. How do I move? All right, as I indicated earlier, that BNHI has been polling the public on the satisfaction of NHI since 1995. What do you think people's recent rating? Okay, next question. So you guys are more positive about NHI than the average citizen. Okay. All right, the third question is, what are the most common complaints against our NHI system? All right, this is actually a multiple choice. So I'm going to ask you again, assuming that that is your second highest complaint. So we'll move to the next question. I think, yes, do it again. No. Can we do it again, Maisha? Can we do it again? No, we don't need to do it again. Can we repeat it?
Yes, just select your...
How do I do that? Oh, okay. All right. How do I do that? Okay. We move to the next question. I have too many choices here, right? I can have only maximum of 6. Okay. All right, so you can only have 6 choices. This is my... Okay, please answer the question. What, in your opinion, are the most important factors to a successful NHI? Okay. Do I have other questions? Okay. This is actually our two questions. So we'll do the West first. In the West, the Western countries, which country do you think they have the so-called best? Define yourself according to your own definition. What do you think in the West has the best healthcare system in the world? Number 4, Switzerland. Okay. All right, we'll do it again. Asia. Choose from this side. Yes. Number 1, number 2, number 4. Okay. Very few choose Australia. Interesting. North South Korea. Okay. Do I have more? All right. How do we do this? Okay. This is actually not a multiple choice. It is an yes or no. Do you agree? So we need to do 6 times, right? 1, agree. 2 means disagree. And this is kind of difficult. But yes, I'm going to do that. Okay. The first question is, the only way to prevent waste is user fee, which means those who use more need to pay more. Do you agree or not? Yes. 1 means yes, 2 means no. You don't agree. So we have about 56%, 57 against 38. Okay? Second question. We'll do it again. All right. Those who are richer needs to pay more. Okay, second question. Whoever is richer needs to pay more. Next question. All right, whoever's income is below poverty line, all right, every country defines its own level of poverty line, which means below this line you are considered poor or low income. All right, should not pay at point of service, which means when you in contact of the healthcare system, usually it's a doctor. Doctor's office or in a hospital. Do you agree? 71% against 28. Okay. Next question. The senior. All right. Again, every country defined who's senior. In Greece, 55 years old is senior. So I am senior. But in most countries, 65 years of age is considered a senior person. Do you agree that the senior should not pay any co-payment or any cost at all at the point of service? Okay. 40 against 60%. Okay. Next. All right. Do you agree that children below the age of 3 should not pay at point of service? About the same. Okay. The last one. Those with the so-called serious diseases, such as cancer or congenital diseases such as hemophilia, which means you cannot stop bleeding, you have a congenital defect of a blood clotting factor. In Chinese, it's called 血友病. Do you agree? Those with these very serious diseases should not pay any cost at all at point of service? So most, 2/3 of them disagree. Okay. Do I have more? I don't think so. This is the last one. Okay. All right, Professor Zhang, do you need to do anything? I've just done my...
Welcome our son. Coming here, and who are the students? Where are they? From Yangming University. Where are the Yangming University?
Oh yes, we have our yes.
Can you raise your hands from Yangming University?
Yes.
Welcome to NTU. Later on, probably we have time to kind of introducing yourself to small groups, and hopefully our environment is okay for you.
Very good.
And,
very good. Very fancy.
And so, have you been introduced yet?
Not yet.
Not yet.
I can introduce myself.
It's our pleasure. It's my pleasure to introduce Dr. Hongjien here. He is one of the most important person in kind of steering our national health insurance systems in Taiwan, which is the Taiwanese we are very proud of. Okay, and even in U.S. Presidential campaigns in the past 2 times, and always been talked about. And I believe in the end of the year's campaign, there's both parties in the U.S. will also talk about the Taiwan models in solving these insurance problems as Americans are facing. And so I think he will have a lot of things to talk about. And the other reason we invite him is there's a video, right? Sick Around the World, and he is in the video. We have to make him be here in person to share with you. And our students are quite diverse. Some are thinking our staff are too tough. Some are thinking the staff I have taught are too shallow. So they are engineers, public health, lawyers, and business, finance, all these different backgrounds. So just give you flavors. What you can do, and I believe you can do very well. So let's welcome Dr. Zhang again.
Thank you. Thank you, CHANG. CHANG actually we were in Harvard School of Public Health back in the 1980s. A little bit about myself. I graduated from National Yangming Medical School, so I do have an MD degree, but I don't know. I actually entered public health upon graduation. So I actually came to not this campus, but the campus of the medical school, where I joined have the MPH program of the School of Public Health there, and later, as I indicated earlier, Harvard School of Public Health for Health Policy and Management. After I returned from the U.S. in 1988, I joined the government for 16 years before I changed my career as a biotech venture capitalist. So I am full-time investment now. During the 16 years, most people knows me because I was at one time I was head of BNHI. It was during that period, between 2001 and 2004, that most people knows me about this and about these international interviews. Although some of the interviews, including the one I'm going to share with you later, is actually they contact me during the previous American presidential election. They thought it was going to be the #1 issue of the campaign, but the economy was worse. So it's actually the second. So they did this program. It's called Sick Around the World, which literally means how different nations treat their patients. All right, that's the name. They selected 5 countries, and one of them is here. So they came here to interview, among others, interview me. I teach as at Yangming. The course is case studies in health policy, so it's our pleasure that some of the students can join you guys here today. So, rewarding, boring. All right. Rewarding, boring. All right. I do not really intend to give you a big lecture. All right. Before I do that, I think we have. This is the first time I'm really privileged that we have many international students here. I believe this is the first time I have so many international students. Back in Yangming, we do have a small class of some international students. So would anybody want to share with us your view on your country and your system? Anybody? I just talked to Zhonghui. She's from Costa Rica. She said, Zhonghui, your country? Yes. It's okay. She said that it's a bit like Great Britain. So, anybody else? Anybody from your country? Nobody really want to comment or share with us? Anybody been to a hospital here? Mm-hmm. Yes.
Said I had my appendix out.
Oh.
It only cost me $200.
All right. Do you need to pay out of pocket?
Only 7,000 NT.
7,000. But you are not covered in our system, right? You are.
Yes.
Mm-hmm. Mm-hmm.
And I went to the doctor. I went to the hospital in the U.S. It cost me $35,000.
Oh, you are also from the U.S.?
Yeah. It's so expensive.
It's so expensive there.
There's always co-pays everywhere you go. And I mean, I'm part of Kaiser.
Kaiser is very famous.
Yeah, no, it's a great hospital facility and everything, but everything costs money. It's great service, but my parents have had personal issues with money, with like just, they just charge you for random stuff and they call you all the time. And I remember my dad was having a conversation with someone and he said, no, I'm not paying that, because he's like, it's kept charging you. And I didn't get the specifics of it, but it's just you're always paying money, like for prescription. Kaiser, well, with my experience, they try to give me the generic brand for something for me to pay less, and it's still like $50 to $70 to get my medicine.
Oh, 50, 70 US dollars to get your, for a couple of months of medicine, right? It's quite expensive.
Yeah.
Even in American standard.
Yeah.
Anybody else want to share with us? Yes, please. Where are you from?
Okay, I'm from Honduras, and healthcare back in Honduras is really cheap, but most of the expenses go to the employers. So many people work as house keepers or helpers. So the poorest or the people who earn the lowest salaries cannot, or the employers cannot afford to pay their health insurances. So mostly maybe around 50% of Honduras is not covered by health insurance.
So in your system, it's the employer who's responsible to pay for your premium of health insurance, but many of the employer cannot do that. So you estimate about 50% of the people are not covered. When they are not covered, every time they get sick, they pay out of pocket, right? Thank you. Anyone else? want to share with us? Anyone who has? Most of you are too young to have a significant, except from our, what's her name? Haitian. Yes, you had the pen. It's actually, you cannot control it. Just as the Swedes doctor said that, or it's kind of a stroke of luck. It just happened to you. We cannot really predict that. That's a risk. Anyone else? Anybody want to share with us your experience? Or you want to give any comments? Okay. Let me, how do I operate this? Our healthcare industry is actually a very complicated system. So there are many experts who are trying to improve systems, business school, management gurus, and everything. But in my opinion, this system is so complicated. It's very difficult to do it or to build a so-called perfect system. But we can always learn from everything. Okay, so this is 2003. The video when they did the video, it was back toward the end of 2007 when I was already left the government. I left the government in 2004. In 2003, actually, ABC News interviewed me. That's a very short summary I gave them in contrast with the American system. I told them that the average citizen pays about $20 per person per month. That's the premium. And we can go to any doctor, any hospital. When we really, at the point of service, as I did on the survey, at the point of service we pay about, on the average, $2 and the maximum about $10 each visit. It was back in 2003. It's a little bit more expensive now. That is our system. I want to share with you some of my observations. This graph is from World Bank. It's about China, which now become one of the global power. And you can see that you can see this line. This is called state funding. State funding. This is the out-of-pocket payment, or OOP payment, directly from the public. So they started their so-called economic reform in 1978. So everything go market. So the state funding to the healthcare system as a percentage of the total healthcare cost has dropped significantly, and people need to pay. This is a proportion. This is a proportion. At this stage, in 1978, China was held by the WHO, regarded as a model for poor countries. They have a model, a so-called barefoot doctors. They train the villagers who can be trained, the farmers, okay? Because they are, farming, so they are barefoot. They are barefoot. They train them very basic knowledge and get every body a basic protection of health. That model was so successful. WHO thought at that time, back in 1978, if China could have done that, everybody can do that. So they gather at Alma-Ata of Kazakhstan, and then declare health for all by 2000. This health for all by 2000, we know by the year 2000, it is not achievable. So I believe that Professor Zhang has previous classes teaching you about the Millennium Development Goals. Millennium was the year of the 2000. So this is very, very difficult. Look at China. When they were poor, they have universal health care. When they get rich, that become a problem. Okay. I want to show you a little bit about numbers. So that this is actually graduate school stuff, but this is not that complicated. When we're talking about, if you watch the video, there are certain terms coming up. One thing is called healthcare expenditure as percentage of GDP. Those who trained in economics, those who are not of you are not trained in economics, this is not a very difficult term for you. This is the gross domestic product is an indicator for economic growth. It's a sum of the national output. So this is usually used as a benchmark. So a percentage of GDP, you can see that the total health expenditure, this is the number is for Taiwan. Starting from 1983, we start for around 4%, and then to about 6.2% back in 2003. But there are actually three components of it. The one pink line is the direct government spending on public hospitals, on prevention, on vaccines, on public health. The major chunk here, 1995 was the year that Taiwan has this national health insurance. So we see a jump here. So this is the so-called social insurance. The green and the pink together is considered health spending by the public finance of health spending. The blue one is the out-of-pocket payment. These are the costs you pay directly out of your pocket. It's the OOP. Okay. I'll show you later that this concept is very important. This is one typical indices that we use to gauge among different systems. Okay. Maisha actually met me there back in 2006 when I was invited to talk at Healthcare 2021 in Prague, Czech Republic. I'm not sure if you have students from the Czech Republic, but it's extremely beautiful country. I chose this subject, and then I want to share with you a little bit about this concept. It's money or life. It's about money, and it's also about life. So that is why it makes healthcare so difficult. In the video, you show the statue of this famous person, von Bismarck. So now we call it the Bismarckian models, because Germany was the first nation to have invented this socialized social health insurance. And Japan, Meiji Ishin. Japan was the first Asian country to have introduced it back in toward the end of the 19th century. This is a very famous movie. They won an award back in 1983. But it's about the story of this small village, mountain village called Narayama. Narayama, Bushiko literally means that they have a tradition. The tradition is that because the village was so poor, so when you reach certain age or you are sick, you will be carried to the top of Narayama, and then you will die naturally to save the resources. Okay. So when this it's actually in the beginning is a is played on a stage. So the New York Times, back in 1961, when it was first staged in the Broadway, they had this comment: the custom, harshly implacable to Occidental, which means the West, of transporting the aged and the infirm, those villagers, to the barren heights of mountain Narayama, where a rough nature soon solves the problem of feeding and maintaining them, which means let them die naturally, to save the resources. In the Japan of long ago, the approach to the geriatric enigma was drastic but simple. So, we always need to face choices about life and death, about who to treat or who not to treat. All right, so this is a very interesting. In the video, the Swiss doctor said that it will be it will be a scandal if anybody get bankrupt because they need to pay. All right, you go to the British, the United Kingdom, nobody needs to pay. Okay, and here we pay a little bit or not too much, but still people think. It's still, some people still think it's too expensive. It's always there, but so cost is always a problem. Let me share with you that when I was at Harvard, that a professor of economics asked the question. He asked the question that because it's in School of Public Health, he said, "I believe none of you would oppose asking people or persuade people to stop smoking, because we are all School of Public Health." Okay, but for various reasons. But one reason very commonly be quoted by our asking people to quit smoking is that because smoking will get you sicker, so that if we can persuade people to stop smoking, we can save health costs. In 1986, when he asked this question, there was none of the evidence to tell about this fact. But in 1997, the prestigious New England Journal of Medicine published a paper. He said that, well, if people stop smoking, there will be a saving in healthcare costs, but only in the short term. Why is that? Eventually, smoke cessation would lead to increased healthcare costs. Do you know why? Louder?
People will live longer.
Because people will live longer. How unfortunate. When we save people, we need to spend more, right? Is that the same about Narayama Bushiko? You let older people die, you let sick people die, then we can save money. So money only is part of the equation. We need to think about that. That's the difficulty of healthcare system. It's not like business. In business, some of the things are much simpler. You cannot afford, that's your business. You don't have money, well, you need to earn some, right? You cannot afford a jewel, that's your business. You cannot feed yourself, that perhaps is a government, but economics, they do not care who's rich, but in healthcare, we do care life. And there is always a debate whether healthcare is a right or a privilege. Okay, let me tell you something about life. How much do you value life? Okay, there are ways to value life. This is the so-called economic evaluation. There is one method called willingness to pay. It's actually a survey method. So let me do this. There are two pills. We'll do the black pills first. I now have a black pill. Okay, if you swallow it, you will die instantly. You follow me? I have a black pill. Do I have a black pill here? Okay, imagine I have a black pill here. Okay, if you swallow it, you die instantly. Okay, The question is, how much should I pay you so that you want to swallow it? How much? Anybody? Are there people that, regardless of how much I pay you, you will never swallow it? Raise your hand. Regardless of how much. Billions, hundreds of billions. Okay. So for those, you just raise your hand. Life cannot be bought by money, right? Okay. Now, I have 9 other black pills. They taste and smells exactly like the one which can kill you, except that they are made from flowers. So you won't die. Okay? So I mix with them. So I put it in a bin. How much do I pay you so that you want to draw one among the 10 so that you would swallow it? In a sense, it's a 10% chance, right? How much should I pay you so that you want to draw that? Anybody want to give me a ballpark? How much? 10 million? 10 million? 10 million NT dollars? It's not good enough. How much? No, you don't want to try. Okay, let me say I have 99 black pills, which is innocent, and then only one is toxic. 1%. Do you want to try? Okay. This is the black pill, right? Okay. So the economists do this kind of survey trying to see how people value your own lives. This is the so-called black pill experiment. Okay. But there is another experiment that perhaps we are more familiar with, which is called the white pill experiment. Okay. Suppose, I won't give you as an example. Suppose somebody is dying, and I have a white pill which can treat this disease. Okay. If my pill can cure you, for sure, how much would you want to pay? I can do the white pill. If the white pill is 10% chance to cure you, or 1% chance of cure, how much are you willing to pay? Or if I say that the disease has 100% of killing you, or only 1% of killing you, my pill is definitely effective. So I can more kind of mimicking the real world healthcare system, and then we can have this graph. For black pill, the real actually this scholar, he actually did this survey, and he said that for probability more than about it's about 10%. Nobody is willing to. Most people are, so it goes to infinity. Okay. But for lower risks, people are willing to accept, even sometimes to accept lower than $1 for probability lower than 1 in a billion. No way, right? Are we taking such risks? Well, this is something. This is something we'll know. But in the white pill experiment, the so-called true economic value of life is bound by what? There is a finite number. Why in this previous is infinite? But why here it's bound? There is a maximum. Why is that? Why is it bound? The value of life. Anybody? Bound by what? By our, it's not our willingness to pay, right? I'm willing to pay $1 billion, but I don't have $1 billion. So it's bound by what? income, bound by our ability to pay. That's different. In this situation, you are the receiver of money. You need to ask me whether I want to pay you 10 million or not, right? Okay, but in this case, we are the paying. So it's not only willingness to pay, but it's also ability to pay. So our willingness to pay is bound by our ability to pay. Japan used to have free. That's one of the questions I ask you. Japan used to have free zero copay under the age of 3, and also zero copay for the senior citizen. But in 2002, as you see in the video, that their system is not sustainable, which means the money they collect from people, from the premiums, and also from the tax, cannot support what they pay out. So in 2002, they did a co-payment reform. And then again in 2006, all the major reforms try to increase co-payment for the senior citizen, for the ordinary citizen, for the senior citizen, and the like. So in 2004, World Bank, Ikegami professor was the guy who was interviewed in the video. Ikegami sensei. He is one of the most renowned health policy scholar in Japan. Japan has dealt with financing constraint in light of its stagnating economy. We know Japan now talking about lost decades. In the 1990s, we described lost decade. It's 10 years. Now we are talking about lost decades. Nobody knows what will be the end of Japanese, the so-called stagnating economy. Their economy has stopped growing, and and also they live the longest in the world. Their life expectancy is the longest in the world. So they are facing aging of the society and also stagnating of the economy at the same time. So they are doing their reform focus on people's need to pay at the point of service. That's what Japan did. This young lady, Erica just shared with us that the United States is very, very expensive. I don't need to tell you about that because this has become and there are 50 million almost uninsured. So that's a system. Right? Also in the video you saw Tony Blair. He had the most expensive breakfast because he announced his tax raise to finance or refinance NHS during the breakfast with the journalist. So, the journalists adopted the most expensive breakfast in the history of UK because this is only NHS spending. It's not total healthcare expenditure. NHS accounts about 85% of the total healthcare expenditure of UK. So you see that in the Margaret Thatcher years, it's hovering around 5%, 6%. And Tony Blair started here. So now we see UK is more or less on the hallmark of the international standard. So UK reform resort to increase in tax. And ironically, you may not believe it, but it is a fact that Tony Blair pitched his election by vowing to raise tax to finance NHS. So he is perhaps one of the very few politicians who dare to say that word of raising tax solely because of NHS. Because at this stage, NHS is almost bankrupt. So this is about, in 2004, at Gastein of Austria, I met Professor Peter Smith from University of York, and I love to borrow these slides from him. He said, what is solidarity about healthcare? He said, the rich pay for the poor, the healthy pay for the sick, and the young pay for the elderly. Are there countries which does not think, except United States, which does not consider health care as a right? Yes, Singapore is the most notable exception of the industrialized nations. In the mission statement of the Singaporean Ministry of Health, it said that good health is to a great extent the responsibility of the individual. Ensuring Singaporeans have access to good and affordable health care that is appropriate to need, while emphasize the principle of co-payment. So Singapore is the one country which emphasize more on co-payment than anyone else. And China actually modeled after Singapore on their current healthcare system. When China designed the system back in the late 1990s, it's a pilot system. It's dubbed 两江试点, which means pilot project on the two cities. It's called 两江 because the two cities' name, one is Zhenjiang, one is Jiujiang. So they dubbed it 两江试点. It's very famous back in the late 1990s. China thought they have designed or invented or reinvented the best healthcare system of the world. They borrow the concept of the social insurance. They borrow the Singapore's famous medical saving account, MSA, medical saving account, which in the United States called health saving account, which you pay into a pot, and then you use the money first, sort of things, and then they combine deductibles. Deductibles are the concept that in car insurance, you need to pay up to certain amount before the insurance cover you. This amount that you need to pay first is called the deductibles, and then they have everything. This famous or infamous healthcare reform in the 1990s failed miserably in 2005. So even the smartest people in the world that cannot really come up with the system, originally they thought they did. This is a very important slide I want to show you, because also in the video there are phrases that usually said is about life expectancy at birth, which means what is the average years of life you are expected to live at birth. Okay, this is a very technical public health term. In Chinese, we translate into something. It's not accurate, but it commonly used. It's called average lifespan. It's called 平均寿命. But this is not correct, because it's not the average age you die. It's actually it's an expectancy, which means it's calculated with probability of dying at different age, and age 0, which means at birth, is calculated from infant mortality. So the higher the infant mortality, the lower the life expectancy at birth. The reason that I show you this graph, first of all, I want to show you the definition of these two numbers. But the most important is that in the 1960s, I have just described to you, this is the curve for China. The average life expectancy at birth is merely a little bit around 40 years of age. But when they had started to implement the so-called barefoot doctor system that I just told you, that toward the end of 1970s, their life expectancy at birth already approached 70. In contrast, where in India, where they did not have that universal access to basic, very, very basic, you can imagine that they are poor farmers. They are trained only limitedly, but they can prescribe you some of the medications. They can teach you some of the very, very basic, very simple health knowledge. A country can improve their public health indices dramatically without a modern health system. And after China had opened up, these indices barely move. Okay, so investment into a healthcare system is a very tricky business. On this slide, I want to introduce you the concept of out-of-pocket payment. Out-of-pocket payment as a percentage of total health spending is one of the most important indices that in health economics we evaluate or we judge a system. So using this system, the reason is that if the percentage of out-of-pocket is lower, which means health spending relies more on public funding or public financing. I have already shared with you in the previous slides that the definition of public funding or public financing is the combination of direct government spending and social insurance. Okay, so we can see that Japan ranks #1 in Asia. The reason that we love this percentage OOP payment to be lower or in reverse, the public spending to be higher, because public financing usually means it's more equitable, which means it's more fair. The rich pays more, the poor pays less, or the sick will not be overburdened because he or she is just unlucky to get the illness that we are healthier. So you can see that Japan actually ranks #1. Most of the industrialized nations that their OOP is typically below 20%. Although Taiwan is considered one of the good systems in the world, we still rely about 1/3 of our payment from our people. But other Asian countries rank even worse. So this is one thing that I want you to bear in mind. The following slides, I want to share with you some of the comparisons. That this is very old data, but the trend is still the same. The United States ranks the #1, but most of the so-called industrialized European countries, Western countries, their spending is around 8 to 10%, and Korea, Taiwan is at that time is around 5%. This is the absolute. These numbers are the percentage of GDP on healthcare. So this is one indices that very often used to compare different countries. This is the absolute numbers. Absolute numbers are difficult to compare, but in this graph, they are using the so-called adjusted for cost of living difference. It's actually the P adjusted. This is an economic jargon for that. So you can see that on the average, the U.S. spend about twice more than most of the European countries, and about 4 times for Asia. And this is the per capita expenditure on pharmaceuticals. So you can see that the cost is actually higher in France. It's quite a bit surprised, and also United States and Canada. And this is, I don't have Japan here. Japan here, yes. Japan actually leads the world in annual physician visits per capita. We are catching up fast. Don't worry about that. When we get older, we'll be another Japan. Because, just for your reference, in case you don't know that, Japan built the modern healthcare system for Taiwan. So you go to, have you visited our National Taiwan University Hospital near the President office, the old building, Taida Yue, the old building? It was built by Japan back in 1987. Most of the public hospitals, was built, were built by Japan. So Japan, before Japan, the only modern system built was by the missionaries. Okay, so perhaps Professor Zhang will want to share with you that later. Okay, so what do we evaluate a health care system? How do we compare, or how do we benchmark? In the famous report 2000, that's only one report. It's done and nobody dares to do it again. It's the World Health Report. The World Health Organization publishes a report every year. This report is unique in its own way because in that report they dare to compare. They dare to compare. So how they compare? They use overall level of health, so infant mortality, maternal mortality, or life expectancy are the most commonly used indices. They compare not only the overall level, they compare distribution. Usually it's about income. Is the rich healthier? Usually the rich is healthier. The poor is sicker. But we want to know how much sicker or how much healthier. Is the gap comparing, is the gap narrower in one country or wider in others? So this is the so-called distribution. I'll define responsiveness later. WHO was very, WHO thought responsiveness is one of the most important indicator to evaluate a health system. I'll define it later. And also, he used financial contribution, distribution, which means in the system, is the rich paying more or it's only the poor? What is the difference in terms of proportion? So that's what WHO did back in 2000. All right. There is an organization called the OECD countries, and we used to call it the Rich Country Club, the OECD countries. And the OECD, that organization, they have a health project. So they define, they created this term called high-performing health systems. In these high-performing health systems, they use quality. By quality, they mean better health through better care. Access to care, which means how easy you can see a doctor. If you notice, Tom Reed in the video, he constantly asks one single question. How difficult it is for you to see a specialist? In the UK, you are not to see a specialist unless you are referred to. In the United States, usually you need a referral. But in Japan and in Taiwan, you don't need it. You go directly to a specialist. In the video that he uses his shoulder to see an orthopedician or 骨科医生 to demonstrate that point, to see how easy you can access to the care you needed. And responsiveness in OECD, they define as satisfaction. If people are satisfied, then we consider the system is very responsive to people's need. And also healthcare spending. Are they expensive? A percentage of our GDP? So can we afford it? Is that sustainable? If it is too expensive, it's not sustainable. But if it is too cheap, it's also not sustainable on the other side, on the hospital side. You can see that in many countries that doctors complain about low level of financing or a very low price. Efficiency in economic terms, but simply put it, value for money when we pay it. Okay, so what if we want to evaluate our system? So we did something that says, what's the performance of national health insurance in Taiwan? We said that, do we cover everybody? Is that easily accessible? Can we afford it? Is that level of finances sustainable? Is that responsive to people's need? Is that equitable? Is that fair? I noticed that you voted fairness as one of the. Is that efficiency? Do we the money we put in? Do we get the value out of it? Is the public satisfied for that? Okay. So in 1995, when we put everybody together into one simple scheme, within less than 5 years, we have reached people, technically speaking. I often said that the 1% that we cannot reach them are those that even the policemen cannot reach them also. We don't know, we literally don't know where they are. Okay, so this is what really happens, that in 1995 we had 41% of our population uninsured. Overnight, it's not that dramatic, but overnight it's reduced to about 8%. So it's a very dramatic reform at that time. And then later on, that by 2003, the uninsured has dropped to 1.33%. This is the famous IC card, which I think we are the only country in the world which has to use that nationally. It's not really about technology. This technology is not that difficult. But for example, in German, the German cannot have ID card, right? Because your constitution. Yeah. You do? Yeah. So, yeah. But I know but this technology actually from Germany.
We have since I was a little kid, we have
Oh, really?
Yeah, health ID card, yeah.
But can you have an ID number? I thought you cannot have an ID number to link the data.
Yeah, there's only.
You can do that. Okay. We borrowed this technology actually from Germany. The company which helped build this chip is from Germany. So we often say that our health insurance, we copy 3 things from Germany: our health insurance system, our IC card, and our beer. Okay. Okay. So this is another graph to show you the most updated data. So right now, I think we are in a steeper increase. This is the so-called satisfaction survey that I have shown you, that from the beginning, people are not very satisfied with the system. That back in, okay, but gradually, more than 2/3 of the people are satisfied with the system. Okay, This is, I was the president from here, okay, to here, okay? And this is the first time we raise our premium rate. Okay, when we raise our premium rate, but it recovered quite swiftly, okay. So we have, I did ask you, we have very high satisfaction. Actually, this ratio is about the same as what you just did in the class. About responsiveness, this is how WHO define responsiveness. Okay, I try to survey. Overall satisfaction is the one simple question to ask you, are you satisfied with the system or not? But WHO went a little bit further. They said, how do you consider, when you are in the system, your dignity, autonomy, confidentiality, prompt attention, communication with healthcare workers, the quality of basic amenities, which means are the bed sheets clean, or the clinic, and do you have a choice of care of providers? Okay. So this is about responsiveness. This is about the fairness of financing. Interestingly, Colombia has the highest of the world. Taiwan is not part of WHO, so you cannot find our name. So we need to put ourselves in. Actually, it's Professor Rachel Liu of CHANG University who did this job. So this table, we can only have it here because it's not available in the world. Okay? Because Taiwan is not a member of WHO. But interestingly, Colombia, because they are all tax financed, it's considered very, and I'm not familiar with Colombia. Because of this number, so Luxembourg, Belgium, I don't know this country where it is from, Denmark, Germany, Japan, UK, Sweden, you can see that these are the top countries. South Korea is 53, US is about, Singapore is 100. It's only considered fairness of financing. So Singapore system is not fair. China is at the bottom. It's not fair either. Okay, so this is my personal opinion that yes, our universality quite good. It's quite it's not very expensive. Equity is fair, but I think we still have room to improve. Sustainable financing, my opinion is that it's more or less an equation of willingness to pay. There are systems which is much more expensive than Taiwan's, but people complain less than ours. So it's about the society's collective willingness to pay. I think our performance in responsiveness on the average is fair to good. And it's very efficient. Our system, I think, is highly efficient, too efficient in a sense. I think we need to be a little bit slower, not like Japan. We have very high satisfaction rate. So overall performance, you can judge by yourself, compare that, but this is a very difficult task to do that. So finally, let me share with you what I think the possible factors contributing to the success of Taiwan's NHI. I used the term success that I consider our system after the reform has been a success. So that's my view. You can always run into doctors, professors that they have different views. But I believe this valuation, internationally speaking, most of the international scholars would agree with me on this. And I share with you why I think our system is a success. The one single most important factor is that we have a single-payer system. That's also the question constantly asked by Tom Reed in his video. The second part is also very important, that 90% are, let me do it right. 70% of our hospital beds are privately owned. Only 30% of the hospital beds are owned or operated by the government. More than 90% of our primary care doctors are self-employed, so they are private. So we have a predominantly private healthcare delivery system, and it's highly competitive. Everybody competes with everybody else because our people can go to any doctor they want or any doctor they choose. We have the best information technology borrowed from Germany and anywhere in the world, and Taiwan ourselves is very good at IT. So I think, and we have 100%. It's called claim processing. As Tom Reed indicated, that we pay, our payment system to the hospital, to the doctors are very efficient. Their claim is very efficient. We are one of the most efficient claim processing system in the world. We have very strong generic pharmaceutical industry. Erica just shared with us that if you want to pay less in the US, you use generics. We have a very strong generic pharmaceutical industry, so we keep our drug costs lower. And we still have very strong family support to share with the care of the patient. And last but not least, our healthcare workers works very, very hard. The issue now is not they are not working hard, it's that they are working too hard. They are complaining a lot. Okay, so challenges just for your reference. Okay. This is really a privilege. Thank you, Maisha. Okay. We still have some time left. If you want to have, I won't keep you too long. I know it's Friday night. Yes, please.
Well, okay. Some of my friends from medical department or healthcare department, they accuse that, that the DHI system of ours is a source of, which I say we're a free competitive market, so under circumstances we make our doctors, our nurses working too hard. So is there, from your personal opinion, is there anything we can improve in this aspect?
All right. Can we go back to the survey? Can we go back to the survey? It's a very good question. To the survey. If I am the Almighty, I can change everything. Okay. Go back. Okay. Let's move. One. Next. Okay. What, in your opinion, are the most important factors to a successful NHI? The result. What is number 2? Okay. From the beginning, most of you does not think doctors or nurses certification is a very important factor. Why is that? Is that a job? That's their job, or you don't agree? You didn't vote.
I vote for that.
Oh, you vote for it? Okay.
People now, when we talk about doctor or nurse satisfaction, people will always think about, well, they are satisfied because they want to make money, so they will charge more.
Mm-hmm.
But sometimes their satisfaction means more basic needs, I think.
Mm-hmm. Mm-hmm. So how do we make doctors and nurses more satisfied? All right, I'm not disagreeing with you. All right, yes. Actually, nurses get more sympathy from the public than doctors. When doctors went on the strike, it happens in many instances in history. And usually people joke about that. There was one very famous story about the California doctors went on strike I think in 1980s or something for 1 week. Okay, so later the newspaper said that during that 1 week the mortality rate of California actually dropped. Do you know why? Because nobody is writing death certificate. But they're only joking about that, saying that your doctors are no. Doctors are very difficult to pitch to the public, saying that they are the victim of a system. Nurses are easier. People usually are more sympathetic. So the reason, the so-called blood and sweat hospitals, actually nurses got the attention first. In our Yangmin class, we discussed this. Our students in Yangmin, in the beginning of a class, I said, what issue do you think is the most important? Many of our students said nurses' working condition, low pay, and all sorts of things. I said, the market will solve themselves. Why is that? Why does anybody want to work in that terrible condition? We are not North Korea. Nobody forces you to do that. It's only all your choice. Why people are still working? Yes, please. Well, okay. The reason I said that is that if on this population, the nurse population as a whole, is not satisfied with the working condition, the market will change. When the market changes, on the demand side, patients, or the payment side, we need to change. And it changed. Do you understand what I mean? If the working condition is so bad, nobody wants to do the work. For example, if teachers are so tough a job, nobody wants to teach, and then teachers' salary will go up. That's market. That is market. So yes, there are complaints, but we need to look at the system as that how we solve the problem of whatever, bus driver, policeman, or electrician, or plumber. It's no more different than we consider nurses and doctors. So there is, in our system, because our system is a free market system on the delivery side, so the market will determine that. As long as there are people willing to take the job at that level, particular level of salary, and particular contract of working condition, the market won't change. But if those people accepting the current level are less than we demand, then the price will go up. That's very simple economics. Do you understand what I mean? Very simple economics to me. Supply and demand.
So, but by this definition, Are you expecting that there has to be a collapse of our there has to be a collapse of our medical care system first, then
No.
we have a.
Why do you need to have a collapse of the system first? It's only a raise of the nurses' salaries.
But it seems that there's no one willing to do this. I mean.
It's happening, right? You don't see the newspapers. The President Ma just announced that there are 10 points. They want to raise nurses' salaries, and then they want to limit their work hours. They want to improve their conditions, decrease their paperwork and everything. You guys don't read newspapers.
I do, but the way our government is using are still quite doubtful. For example, they want to decrease the working hour of the working nurse because they want to introduce those who are still studying into the system.
Oh, okay. You don't think that works? Well, I don't want to enter a debate about that, but you have a very good spirit. You always need to distrust your government. That is very important. This is a spirit of democracy. I'm not saying that the government now is doing exactly or all the right things, okay, because we did not have time to present both cases. It's not fair to you and not fair for the government. Either way, I don't know. I'm just saying that the market is a mechanism. The market will send through the signal that we are not happy. We don't want to work in such conditions. And in our system, the government does not set salary for nurses. It's the hospitals as a whole and the clinics as a whole. And we have the nurses, that's the workforce. So there is a balance. I think recently the balance has tipped. Changed. In the past, when I was an intern, we worked 36 hours straight, no complaints at that time. But who cares? That's your generation. In our generation, we don't do that. Your younger generation, why do we need to work for 36 hours? I just want to work 8 hours. So the total workforce will be larger, right? If it takes one doctor to do the job 30 years ago, in my age, when I was young, it may take 1.5 doctors to do the work. That's a new society. And it will be more expensive, that's all. So our healthcare expenditure is higher than 30 years ago. That's just natural. So it's market in itself. What kind of lifestyle we choose? 30 years ago, we choose more money than our leisure times. We don't have this fancy 7-Eleven stuff. We don't have so many movie theaters. We don't have internet. We live a very simple life. We work very hard. We want to maximize our earning. So we work harder. We think that's worth it. That's 30 years ago. So nobody complained about blood and sweat hospitals. But now everybody's complaining. So the world's changing. So the cost got to be higher. So in the end, people need to pay more. That's the market force. And in Taiwan's system, the only place we do not have market competition is that single-payer system. It's the Bureau of National Health Insurance. Yes, in the long run, it will be the source of the problem. Many people believe it already is the source of the problem. But our system as a whole, in my opinion, it's operate quite good to the satisfaction of our people at an affordable cost and also very accessible. Okay? Any comments? Yes, please.
According to your previous point about working condition of nurse, you say that market, their payments will be adjusted by the market, right?
Yes.
But it seems like long-term stuff. And in today's newspaper, there are 400 nurses in Taichung. They resigned in the same hospital, and I think that's a way that they struggle with the system. And to my recognition, in Taiwan, there's no right for nurses or doctors to go to strike, right?
All right. Nurses, can nurses go on strike? Nurses, I think, is that? Okay. Strike. Okay. Let me check that. Strike is one show of opinion collectively that we are not satisfied. So strike, yes, it's a tool very usually used in industrialized modern nations. But strike is only one such. I said that you can always quit. Okay, or as we see it, the newcomers, they stop entering, or they leave the system. The turnover rate is very high. So in market, we see this as a signal that the supply and demand is okay. That's why I'm saying that I see it the signals, as you say that the nurses are quitting collectively. This is a very powerful signal to the employer that we are not satisfied. We won't accept the working condition given the pay level. So I think this change is already happening. I'm not saying that what level is right or wrong. In market system, we don't know what level is right or wrong. We only know after there is a new equilibrium. For example, if the current average salary is about 30,000 for the entrance nurses, and then after these events, 6 months later, the new equilibrium is about 35,000 or 40,000, I don't know. At that level, there are much fewer people complain. Then we'll consider that this is a new equilibrium.
I think they should establish a way for the nurse to do bargains with the system, besides from quitting their jobs.
Mm-hmm.
And is there a way to do that?
Collective bargaining? Collective bargaining is about unions. All right. Yes and no. In Taiwan, I think the collective bargaining is at that you have a nurses professional association. They do try their best to bargain with BNHI, trying to increase and trying to add items. But I don't know. As I know of, I don't think the nurses have a collective way of bargaining, right? Your local, I'm not. I don't. In my experience, I haven't seen such collective bargaining. So collective bargaining is a way that to strengthen the workers, and in economics, it's called union, 工会. Okay. So this collective bargaining has its strengths and its downside. Economists does not really like unions, but a collective bargaining is a way to strengthen your position. But it's also, everything is market power. If you can, for example, if every nurses in Taiwan is united, nobody will accept anything less than a given number. Then the wages got to go higher. This is what the many countries' workers do. What I'm saying is that this is a market phenomenon. When we see so much of the complaint, then from the market side we say that no, the working condition and the price, the salary at this time cannot attract sufficient workers to work at this place. But I don't know when is a new equilibrium. It could come very soon, as I judge from this beginning of the semester of my class is only 2-3 months away. I see things happening very fast. Perhaps I am an outsider, so I think it's fast. If I'm an insider, I think it's slow. But either way, it's happening. In the past 10 years, I think this year is the most dramatic year that I have experienced as an observer of the healthcare system. Okay, thank you. Perhaps one last question if we have. Yes, please.
Okay, I think Taiwan's national health insurance is really cheap. I paid, 50 NT for doctor's appointment and the medicine here at school, and not more than 100 outside school. As we saw in your presentations, people still complain that it's kind of expensive, right? Do you think there's there's some background, or really prices are still high, or that just people need to complain about something?
Very good point. All right. Well, complaint is a very strong, very powerful tool against a single system. You always need to complain. Otherwise, we are afraid they are going to do something bad to us. All right. Yes. I think people just complain is one factor, but there are people whose income or their cash, their disposable income, the cash they are free to spend, is much lower. So if you go to the countryside, the southern Taiwan, that I think their complaint is genuine. So I don't think that people complain just for complaint. But in the city, I do agree with you that some people just love to complain for complaint's sake. But in the rural Taiwan, especially in southern Taiwan, I think for those people, they do not have cash to be disposed of. Even 50 NT dollars is significant, affect their daily living. For those marginally, they are not that poor, but their cash is not that sufficient.
And can prices still go lower, or?
You mean Taiwan's prices?
Yeah,
I don't believe so. We are so low, already so low. I don't know how we can go lower. I don't believe that. Yeah, thank you.
I think it's worthwhile, even if it's late in Friday. Dr. Zhang gave us this very important health insurance, or healthcare systems, from a global, historical, and even ideological perspective to view these very important 21st century issues. That's what our global health course is about. In the coming decades, you will be, bombarded by all these kind of health insurance, healthcare industries. All these things are very important for all our humankind, poor or rich. And I think he has done an excellent job to introduce you to learn this. And I believe some of you in the coming decades will work on these issues in the industry, in the government, or as individuals. So with this, may I ask you to give Dr. Chen another applause?
Thank you.
Thank you.
Thank you. Thank you. Thanks. 谢谢. Thanks. Oh, yes.